Thank you, Michael. So, this is my topic, how policies and repressive law enforcement fuel the HIV epidemic among people who inject drugs. Why isn't it going down? Is there a trick?
Right here. This one.
Okay, thanks. Thank you. So I want to talk about policy and HIV epidemics first up. And I'm going to talk about how government policy restricts HIV prevention programs or restricts the scale-up of effective programs. I'm going to use the case study of Russia. We've heard a little bit about this already. There's no opiate substitution treatment in Russia, and there's very limited NSP. Yet Russia is home to 1.7 million people who inject drugs, of whom 37% are HIV positive. And we've heard about Russia's ban on methadone has been extended to Crimea. And we were just able to see a video, and 800 people have been kicked off the program in Crimea in May. The next case study I want to draw your attention to is the US and its federal ban on funding needle and syringe programs. The ban started in 1988, just when the epidemic was really getting going, and it lasted for 20-something years. Then it was repealed by Obama in 2009, but it's since been reinstated. So the ban is not just on needle and syringe programs in America, but any programs overseas that America funds. America is home to 1.8 million people who inject drugs, and 16% of those are HIV positive. There was a study by Ernie Drucker and Peter Lurie, and they worked out if the US had adopted needle and syringe programs like Australia had, about 5,000 HIV infections would have been avoided every year. I want to look a little bit more globally here. These are countries without needle and syringe programs in the community. In that first column, there's 72 of those. 81 countries do not have opiate substitution treatment in the community. And 149 countries do not have ARV treatment. If you look in prisons, the situation is even worse. 185 countries do not do needle and syringe programs in prison. 160 countries do not do methadone in prison. And 153 do not do ARV or do not provide ARV. And when you consider about 30% of prison populations of people who inject drugs, it's quite a shameful situation. Even countries who do have these programs, the coverage is not very good. This is a global estimate from 2010, where about 8% of people who inject drugs have access to NSP at a reasonable level. 8% have access to OST at a reasonable level, and just 4% have access to ARV. Now I want to look at law enforcement and HIV epidemics. In particular, I want to look at how law enforcement increases the likelihood of sharing syringes, and the incarceration of people who inject drugs, which increases HIV transmission. So we've heard how people get arrested for having drugs, they have syringes confiscated, police drive drug users away from services. They interrupt people going for OST or ARV treatment. Stephanie Strathty did a study looking at female sex workers on the border of Mexico and the US, and she found that female sex workers who injected were much more likely to have HIV if they'd had their syringes confiscated by the police. The next thing I want to look at is law enforcement and the increased incarceration of people who inject drugs. They're arrested, they're registered, they have to report to the police. All of this leads to a mass incarceration where the level of people who inject drugs in prison populations ranges from 30% to 60% versus 1% in the community. Even in Australia, about 50% of people in prison have a history of injecting drugs. They're often detained without access to prevention or treatment. There's numerous studies linking HIV infection to a history of incarceration. Syringe sharing is very prevalent, often with multiple partners. There's been HIV outbreaks in Thailand, Russia, Iran, Lithuania. I just want to say something about closed settings as well. Often countries have rules and laws where people are incarcerated for simply being drug users, and they're held in closed settings. If you don't know about these places, you should look them up. They're not drug treatment centres at all. And Adiba gave a talk on these yesterday. So I'd like to end with some recommendations, keeping with the conference theme of scaling up. One of the best things we could do is scale up drug treatment in the community, credible drug treatment, such as opiate substitution treatment, NSP, ARV. We really need to keep educating people about the benefits of harm reduction in and out of prison, and the harms of arresting and imprisoning people who inject drugs. We need to work with the police, encourage them to refer people to treatment, and train them how to manage intoxicated offenders, help them managing needle stick injuries and occupational health and safety. We also need to work with prison officers and prison authorities. You need to find a champion in those settings who can help you do what you want to do. And we need to shift resources from supply reduction measures to demand and harm reduction measures, which we know work very well. And I would just like to acknowledge these people who've helped with my presentation. Thank you.